glandular lesions in cervical cytology. So, what are the sources of abnormal glandular cells in pap smears? These are endocervicals or endometrials. Then you can have cells from fallopian tube or ovary or peritoneum or distant metastatic sites or direct invasion from colon, rectum or bladder. Coming to most common cells which are seen as glandular cells in pap smears are endocervicals. We are well versed with these honeycombs and picket fences or endocervical cells, and at times they can show these rosettes. And note the basally located cytoplasm nucleus with this kind of sieve-like finely vacuolated cytoplasm. Endocervical cells usually have fine granular chromatin in round nuclei. They can have nipples and binucleation and multinucleation with juicy cytoplasm. As opposed to endocervical cells, endometrial cells are smaller in size. They can have this top hat appearance with central stroma surrounded by epithelial cells. Note the nuclear debris or apoptotic bodies present within the cluster. You can have cytoplasmic vacuoles. The nuclear shapes can vary from crescent shape to kidney bean shaped nuclei. Chromatin is empty looking or degenerate with this kind of nucleoli, tiny nucleoli can be seen. So this is like tabulated form or between differentials or endocervicals versus endometrials. They are larger. Their hair size can vary, hair shapes can vary, but size will remain small. These are three-dimensional clusters with double contours, top hats. These are honeycombs and picket fences. Multinucleation is more common in endocervicals. And endocervicals, they show pale, fine chromatin as opposed to smudgy dark chromatin of endometrials. Normally, endometrials can be seen up to 12th day of the cycle, and after 25th day of cycle, again we can see endometrial cells, and they can be seen as a part of exodus. But inappropriate shedding is when these cells are seen in day 14 to 25, especially in more than 45 years of age. We must report them, and there can be anything happening in endometrium can lead to inappropriate shedding of normal endometrial cells. There are some benign variants of normal glandular cells, and we will talk about these like reactive endocervicals, TEMs, LUS, and IUCD changes or fimbrial remnants of fallopian tube. Coming to Bethesda 2014, we report glandular cells as atypical AEC, endometrials, endocervicals of AGC NOS. When it comes to favor neoplasia, it is AEC like endocervical cells or glandular cells favor neoplasia, AIS, and adenocarcinomas of different types. Reactive endocervical cells as opposed to normal endocervical cells will show slight nuclear enlargement. This nuclear enlargement can be huge also, but once you see smooth, thick nuclear membranes, prominent nuclei, you should think of reactive endocervicals. Another clue is sometimes you start seeing polymorphs going within this cluster, multinucleation in endocervical cells, prominent nuclei, mitosis. These favor reactive situation as opposed to adenocarcinoma in situ condition. When it comes to AEC NOS, we will see more architectural abnormality. You have this reactive more architecture which is showing more crowding, multi-layering, multinucleation with high NC ratio and markedly granular chromatin. So some architectural, some nuclear abnormalities which are falling short of glandular neoplasia or adenocarcinoma in situ, but they are not fitting with the reactive situation also. When we call it endocervical cells favor neoplasia, these architectural and nuclear abnormalities are much more than endocervical cells NOS. So you will see more crowding, overlapping, more of strips and sheets, more cellularity of endocervical cells, more of rosettes and occasional feathering, hyperchromasia, nuclear enlargement. The nuclei have started elongating, but they're not going out like snake and appearance is not there, but they're becoming round to cigar shape, and nuclear chromatin is granular. Adenocarcinoma in situ, this is one entity. When it is seen in pap smears, it is picked up, but it's actually a rare entity. The first and foremost thing which strikes you is high cellularity of endocervical cells. So if I see a lot of endocervical cells in a pap smear, I'll think of erosion, endocervical polyp, or adenocarcinoma in situ, or a well-differentiated adenocarcinoma of endocervical type. There will be overcrowding. We can see these short strips, and if you just imagine this bird tail, there is a terminal bar type thing here, and it is showing feathering. So similar feathering is seen here with 3-4 cells coming out. So we call them broken bird tails. We see these rosettes. Again, the nuclei are forming the borders of these rosettes. Drunken honeycombs, pseudostratification, like the nuclei are overlapping and they are showing stratification, bird tail appearance, rosetting and feathering, and shallow microbiopsies. What are the nuclear features which point towards adenocarcinoma in situ? The nuclei, instead of round nuclei of normal endocervical cells, they start becoming elongated cigar shape. So if the endocervical cell shape is showing variation in shape, it is becoming elongated cigar shape, you must think of favor neoplasia or AIS. Granular stippled chromatin, no nucleoli. So unless something is invading an adenocarcinoma or a reactive change, you will not see nucleoli in L cell, H cell, or adenocarcinoma in situ. So inconspicuous nucleoli, irregular nuclear membrane thickness, mitosis can be seen. Snake and egg appearances, like this is an endocervical cell and nucleus is forming the border. So endocervical cell, nucleus bulging out of the cytoplasm is known as snake and egg appearance, which is actually a characteristic feature of endocervical adenocarcinoma in situ. These are again snake and egg appearance showing rosettes, which are like as compared to a normal inverted rosette where nuclei are basally located. Here nuclei are going out of the cell, and drunken honeycombs. So in low part they look honeycomb, but when you go to high part, you will see that there is loss of polarity, which is not easy to demonstrate on a picture. And these are semi-rosettes showing a lot of pseudostratification, nuclei forming borders, and nuclei actually coming out of the cells. So these are actually examples of endocervical adenocarcinoma. Endocervical adenocarcinoma on a cone biopsy will look like this. These are normal endocervical cells, and this is adenocarcinoma in situ with a lot of these elongated cells, floating mitosis, and these cells being positive for P16 block positivity and high Ki67. And we must remember that 50% of adenocarcinoma in situ can have a coexisting HSIL, and we should not miss HSIL in pap smears. So this is tabulated form of endocervical atypical, NOS, atypical favor neoplasia, and AIS. And strips will be more in AIS. You will see more of nuclear overlapping, more irregular nuclear membranes, less of cytoplasm, high ANC ratio, no nucleoli, marked hyperchromasia, and coarser chromatin in adenocarcinoma in situ. So whenever there is a diagnosis of adenocarcinoma in situ, we must think twice whether it is HSIL or adenocarcinoma, because this is much rarer as compared to HSIL. But HSIL will show you block-like flat edges, and I'll show you pictures of HSIL here. Like this is an adenocarcinoma. We can see snake and egg. There is a naked nucleus here, hardly any cytoplasm, as opposed to this block-like microbiopsy, which is thick in the center. You can't see through the center. This block means that this is at least 4 cell thick or more than 4 cell thick, and the cytoplasm is all around the nucleus. There is a rim of cytoplasm all around the nucleus. When HSIL involves crypts, there can be 2 types of patterns. One is wrapping, one is pseudopalisating or stratification. So if HSIL is there in the biopsy and it is lifting the endocervical lining, if the cells are picked up from here, it will show wrapping, squamous wrapping. And if the cells are present within the epithelium and they are picked with the brush, you can mistake them with glandular lesion. So it will show stratification. So most of these microbiopsies, which are HSILs, can have an endocervical edge and can show this kind of falling off atypical cells from the microbiopsy, like tennis rackets. So the tennis racket, because the cell cytoplasm is all around the nucleus. So that means this is an HSIL lesion rather than a glandular lesion. When it comes to adenocarcinoma in situ versus adenocarcinoma, you will see more of invasion, like features of invasion. With diathesis, cytoplasm is much more reduced. And the most important thing is now with invasion, you start seeing macronucleoli. You can have architectural features or AIS retained even in a well-differentiated adenocarcinoma. So this is adenocarcinoma. Another thing is TEM, which should be differentiated from adenocarcinoma in situ. These are also strips of and glandular cells. They are tall, columnar, they are hyperchromatic. But look at this. This is like a closed zip. You have terminal bar all around on both sides, and it is like a closed zip. Both pictures to show this closed zip, the cells are coming from both sides and they're fitting into each other. And the diagnostic feature is demonstration of cilia. So if you are able to see cilia, terminal bars, there are parallel side short strips, nuclear enlargement can be there. It is TEM rather than endocervical adenocarcinoma. In LBC, actually, if there is a differential between TEM and endocervical adenocarcinoma, you can make a cell block and do P16 and BCL2. BCL2 will be positive here and P16 will be positive here. LUS is another sampling thing which should be taken care of. It will show these large biphasic clusters, which biphasic means there are these sesame seed-like stromal cells and there are epithelial cells. So they are coming from isthmic region of the uterus, and most of the times they are seen in cases where there is history of treatment with cone biopsy. So the cervical length is small, and that is why your brush head is actually sampling the lower uterine segment or isthmus. Coming to endometrial cells, when do we call something as atypical endometrial cells? I would say endometrial cells are always in small groups. You do not see too many endometrial cells in pap smears because they are shed cells. But if the cells are showing nuclear enlargement, prominent small nucleoli, they may qualify for a diagnosis of atypical endometrial cells, as opposed to endometrial adenocarcinoma, where quantitatively maybe the cells are less, but qualitatively these are very bad looking cells. You will see very prominent macro nucleoli, which are cherry red like nucleoli, and in addition you will see these bags of polys. These could be tumor cells or histiocytes which are engulfing these polymorphs. So berry-like clusters plus bags of polys will the diagnosis is endometrial carcinoma. This is grade 1 endometrial carcinoma. See the nuclei are forming the borders and you see prominent nucleoli. Grade 2 with prominent nucleoli. Grade 3 showing a lot of nuclear atypia, cannibalism, cell eating another cell, and prominent nucleoli. You see a lot of leukophagocytosis in endometrial adenocarcinomas, and leukophagocytosis, a lot of macrophages, apoptosis in the background, again favors an endometrial carcinoma. And sometimes, because endometrioid carcinomas can show schimoid differentiation, you can see schimoid cells in the background of these pap smears also. And these cytological features have been well described in this particular publication of endometrial adenocarcinoma. A word of caution: when endometrial carcinoma is involving lower uterine segment and your brush head goes and picks up these cells directly rather than this being shed in the vaginal fornix, you can see tall columnar cells. And here it is very difficult to differentiate these endometrial adenocarcinoma cells from endocervical cells, because these cells have been directly sampled rather than endometrial carcinoma, which is there in the uterine body and it is shedding cells and the brush head is picking up the cells. So when these are shed cells, they will be berry-like, ball-like clusters. When it is directly sampled, they can look like tall columnar cells. But again, we do not see snake and egg appearance in directly sampled endometrial carcinomas. So differences between endometrial versus endocervical adenocarcinomas. Endocervicals will show more of macronucleoli, multiple nucleoli, strips, rosettes, sheets, as opposed to tight ball-like clusters, berry-like clusters with very prominent nucleoli in endometrial cells. Another tumor which can be seen in pap smears is endometrial serous carcinoma. You don't have to report them as serous, But if you are able to report them as serous in pap smears, then maybe the extent of surgery may be different. And all you need to do is suspect endometrial serous carcinoma, make a cell block, and do P53, ER, and vimentin on these cells. If P53 is positive, this could be serous carcinoma. So there are more papilloid clusters with bad-looking nuclei with very prominent nuclei. This is an example of clear cell carcinoma. Again, you will just report them as glandular adenocarcinomas. With the presence of postmenopausal bleeding tumor in the endometrial cavity, you may call it endometrial carcinoma, but it is difficult to classify them as clear cell carcinomas. Again, if you have a good sample in LPC, you can make cell block and make do Nepsin A, but most of these cases will have an endometrial biopsy, which will confirm the diagnosis. Another thing which I want to highlight is carcinosarcomas. Whenever carcinosarcomas are there in uterine body, there'll be some epithelial cells which would be picked up in pap smear, and majority of these carcinosarcomas on pap smear are reported as adenocarcinomas only. So out of these 8 cases, only 2 cases showed this stromal component associated with glandular cells. So the most common cells which are picked up in carcinosarcomas in pap smear are only glandular cells, and therefore most of these carcinosarcomas in cervical cytology are reported as adenocarcinomas only. So you have to actually look for stromal component in pap smear. Again, they'll be biopsied, and endometrial curettings will be reported as carcinosarcomas. So in pap smear, I think it is good to just report them as adenocarcinomas or malignant neoplasms. So if it is positive, it will be biopsied. IUCD changes can lead to a lot of reactive change in endometrial cells. You can have these multiple punched out vacuoles. We call them bubblegum cells in endometrial cells, or individually scattered endometrial cells, which can show this kind of degenerate chromatin, Ding cells or coil cells. The differential here would be HCl. So if there is an history of IUCD, what are the different things you should look for? Actinomycotic colonies, bubblegum cells, the endometrial cells showing vacuolation, and again these kind of endometrial clusters showing a lot of polymorphs going in. And sometimes you also see coil related granular material which actually looks copperish in color. So these are the changes which can be seen in IUCD bearers. Prolapsed fallopian tube. Just imagine a fimbria or a fimbral end of fallopian tube, and if this area is seen here in pap smear, so it is like a part of fimbral end is picked up in pap smear. So they are lined by columnar cells, and inside there are the stromal cells, but at times they can be mistaken for a glandular neoplastic lesion, especially when there is a clinical information that there is a growth in the wall. So this should be kept in mind. We cannot go away from tuberculosis in our scenario, and in LPC, I think first thing which strikes you when there is tuberculosis are presence of giant cells. When you see a lot of giant cells, your differentials are, can it be radiotherapy induced changes, or tuberculosis, or atrophic smears showing just giant cells like anything, or foreign body type of giant cells in maybe associated with suture material or something like this. So these are actually granulomas seen in LPC, and there are giant cells, and follow-up cervical biopsy showed granulomas. A rare case of rhabdomyosarcoma. So anything rare, uncommon can also be seen at times in pap smears. So these are like strap cells. You can see this kind of striations, and it's a elongated cell seen in pap smear. So these are again rare cells, rare cases. I'm just showing for the completion purpose. Small cell carcinoma of cervix. Again, the chromatin here will be salt and pepper type, and that is the most important thing to be picked up. Small cells, they're around 2 times the size of a lymphocyte. They show this typical chromatin, no nucleoli. When you suspect it, you could do CD56 or a neuroendocrine marker, or even on the LBC sample. This has been done on LBC sample itself, and you could report it as small cell carcinoma of cervix. When it comes to extrauterine adenocarcinomas, most of these adenocarcinomas will not show any diathesis. Sources can be ovary, fallopian tube, peritoneum, or other GI malignancies. Typical case of papillary serous carcinoma with psammoma bodies. At times, we've seen low-grade serous carcinomas also in pap smears. A directly sampled ovarian carcinoma, again showing tall columnar cells. The pap smear was actually full of cells, so we thought maybe it is an endocervical adenocarcinoma, but it was a metastatic ovarian tumor. Lobular carcinoma of breast, showing intranuclear inclusions, magenta bodies, those intracytoplasmic bodies. So invasive lobular carcinoma is much more common than ductal carcinomas, and it will show this kind of Indian file pattern or vertebral columns even in pap smear. This is invasive ductal carcinoma of breast. So these are rare cases. Melanoma can be seen in pap smears, and a metastatic colonic adenocarcinoma. Again, the pattern here is like it is showing a lot of nuclear palisading. So if there is a known history of colonic carcinoma and you are seeing these kind of sample with these kind of clusters in nuclear palisading, you may report it as colonic adenocarcinoma. Again, if you have LBC, you could do SAT-B2 or CDX2 or even on pap smears. So algorithm, I would say, first of all, ask yourself whether it is a glandular lesion or a squamous lesion. If you are not certain about glandular versus squamous, it could be a non-glandular lookalike like HCL involving crypts. If you are sure of glandular, think whether it is endocervical or endometrial, and whether it is normal, reactive, or abnormal. Glandular lookalikes, which could look like normal reactive conditions like TEM, LUS, IUCD, and rare things are like tubal metaplasia or tubal remnants. And atypicals are atypical adenocarcinoma in situ, adenocarcinomas are endocervical type. Non-cervical also we use sometimes a term like non-cervical, which would include endometrial, extrauterine, or adenocarcinoma of uncertain origin. So in take-home message, I would say that pap smear actually facilitates recognition of glandular lesions of cervical and non-cervical origin. We do pap smear just to recognize squamous lesions. Rate of reporting of AGC in pap smears is around 0.08 to 2.5%. So when in doubt, go for squamous, because anyway glandular lesions are less common in number. Cytological features between glandular and squamous can overlap, especially when HCL involves crypts. It can look like AIS, and HCL can coexist with AIS. So when in doubt, you can actually do P16 even on pap smears or a cell block obtained from LBC sample. ICC for P16 can help in identifying endocervical lesions, because we know that endocervical adenocarcinomas, the HPV status can be 60% to 100% also. So I would say, I know the world is going towards HPV testing, but there is a role of pap smears. A lot of HPV positive cases will ultimately need a cervical cytology for confirmation, even if we go for primary screening by HPV. And this cancer is preventable, and we need the will to fight this cancer. With this, I hope that we are able to meet the 2030 target, which is towards eliminating